Okay, let's get started. Well, hello, everyone, and let's do a time check first. It's 2 p.m. in Singapore on Wednesday, November 17, 2021. On behalf of the Singh-held Duke-NUS Global Health Institute, I'm delighted to welcome all of you. I'm Amina Mahmood. I'm Deputy Director of the Institute, and this talk today is part of our monthly Global Health Seminar series. We actually usually host them every last Friday of the month, but this time due to speaker availability, we had to change the date and time, and thank you all for accommodating this change. We're delighted to have you all on this mid-month presentation. In these Global Health Seminar series, we usually draw on our faculty as well as guest speakers to present topics of global importance and really engage with our community in Singapore and beyond. So I hope we have a very interactive session. This is, we will have formal presentations, but we wanted to be, free to have a discussion about the important issues raised. So today we're delighted to have a team with us who will present the results of a project which is supported by our institute. And this project examines the burden of respiratory diseases in children in Vietnam and in Indonesia. I will introduce the PI of the project, Associate Professor Jan Hau Lee, who will then in turn introduce his collaborators from Vietnam and Indonesia, and they'll be presenting the results of their countries. I'm really excited to hear this. So turning to Dr. Lee, who some of you I think might in the audience might know, he's a senior consultant at the Children's Intensive Care Unit at KK Women's and Children's Hospital in Singapore. He holds the academic rank of Associate Professor at Duke-NUS Medical School in Singapore and is also one of the very key faculty of our institute. He is actively involved in promoting pediatric critical care research collaboration in Asia via the Pediatric Acute and Critical Acute Medicine Asian Network. That's a mouthful, but it's called PACMAN for short. In the interest of time, I've kind of kept his bio short, but I do want to note his passion for improving pediatric care in the region really shines out, and we're so delighted to have him and his team present with us today. Before I hand over to him, a few housekeeping notes. Please keep yourselves on mute. Please note the webinar is being recorded. You can post your questions in the chat box at any time, and they'll be addressed at the end of the presentation. But alternatively, you can also raise your hand, and we'll call on you to verbally present, to ask your questions, and they'll, give it a more real life, interactive feel. So over to you, Jan Hau.
Yep. Thanks, Amina, for that kind introduction, and thank you everyone for joining us today in Wednesday afternoon. And I'd like to thank the speakers today from Vietnam as well from Indonesia, who will be sharing their experience with us with regards to respiratory illnesses in children. So we have two talks today, and to kickstart our session, we'll be focusing on Vietnam first and then moving on to Indonesia. So for the talk from Vietnam, I'm very happy to introduce Dr. Phan. So Dr. Phan is a pediatric critical care specialist at the National Children's Hospital in Hanoi and in Vietnam. Besides his medical degree, he also holds a PhD in epidemiology. And he's currently also the deputy head of the medical ICU in that hospital. So he's an active member in PACMAN, and his research interest actually lies in acute respiratory illnesses, ARDS, as well as severe sepsis. So I'm very happy to have Phuc here with us today. And so Phuc, over to you, and look forward to hearing your presentation.
Thanks, Jan Hau, for introduction. Hello, everyone. So, can you hear me clearly? Okay.
Yes.
Yeah. Okay. Okay. So I'm very happy to join the Global Health Seminar series, and like today, I, on behalf of the PI Jan Hau, and I would like to discuss about the epidemiology of critical respiratory disease in ex-premature infants admitted to the medical ICU in Vietnam. Just briefly, as a background, we talk about the premature, and today, as Amita says, that it's not like coincidence, but today is a 17 November. Is a World Prematurity Day for 2021. So a lot of the activity globally today regarding to prematurity, because this is a really still a global public health problem, and approximately about 15 million baby born every year is premature, and majority of them in South Asia and African. And you can see the map. This data published in Lancet Global Health for 5 years ago, but the data still, I think, still now the same. The 5 countries you can see here in China, India, Bangladesh, Nigeria, and Brazil as a country with the largest number of premature baby. And it caused the burden to both in terms of mortality and morbidity, and it accounted for about 16% of global health, and it accounts for 1/3 of the neonatal death. And it's not only during the period of neonatal period, but also later on in the first few months of life, and leading to chronic long-term disease and also increase the medical expenditure. And looking here, it's the burden of the prematurity regarding to mortality. The data you can see that's from the cost of the mortality of death for children below 5. And you see that 45% is due to neonatal death, and preterm accounted for 16%. And not only during the neonatal period, but after neonatal period, it's still accounted for about 2% of all the mortality for children from 1 to 5. And causing of death due to prematurity, it can be direct, causing about 1/3 of neonatal death, but it's also the indirect impact to mortality, including the infection or other events related to intrapartum. And also a neonatal prematurity can lead to the chronic disease. And so one study, big study in France, to see that after 6 months discharge from neonatal NICU, can about 1/3 can rehospitalization because of pneumonia and sepsis and meningitis, and about 70% requires invasive mechanical ventilation. And one of the very last study in UK is a follow-up over 10 years of a 1 million premature baby. And during the first 2 years of life, the chronic condition mostly is respiratory and gastrointestinal condition. But after 5 to 6 years old, neurological disorder, especially the cerebral palsy and epilepsy, is the main concern. And in Vietnam, we follow up a cohort of the patient, and up to 2 years and up to 17% cognitive delay and 7% of cerebral palsy. And rehospitalization is also a very bad consequence of the premature, and especially in chronic lung disease or PPD. And the study in UK I mentioned previously, in the first years of life, for the baby born with less than 30 weeks of gestation, has a 4 times higher of rehospitalization compared to the full time. The similar seen in the EPIPAS study in France, and also in Vietnam, we follow up the more than 200 patients at rehospitalization with nearly 60%. And prematurity is lead to increase the cost of treatment. Here, look at this data in US, it can lead to more than 26 billion per year related to prematurity. And also the lower gestational age associated with the higher cost of care and treatment, not only due to during the neonatal period, but also during the follow-up. And what about in Vietnam? You know that we have quite a big population. It's nearly 100 million population last year, and this data from 2015. And we have nearly 1.6 million baby born every year, and even the mortality, neonatal mortality rate decreased over the last year, but it's still quite different, vary between the region in the country. and prematurity accounted for 1/3 of neonatal deaths. And with the rate of premature about 9 to 10 per 1,000 live births. This is data about 10 years ago, but it's quite similar until now. And in the one of tertiary children hospital, the prematurity accounted for about 1/3 of admission to an ICU. We have a few, but the number, the very limited study on the risk factor and also the long-term outcome of the premature infant, and also the impact of the prematurity on the healthcare system in Vietnam. So that's the reason why, with the support from the Duke-NUS Global Health Institute, we did a pilot study on epidemiology of critical care, critical respiratory disease in ex-preterm infant admitted to the PICU in Vietnam, with the PI is Jan Hau and I as a site PI in Vietnam. The aim of this study is we determine the proportion of ex-premature infant aged less than 2 years admitted to the PICU with a critical respiratory disease. And we describe the etiology and the outcome of this infant with a critical respiratory disease. And we also would like to know the resource use of the patient who has been born prematurely. This is a single prospective observational pilot study for all the children aged less than 2 years admitted to the PICU with a respiratory disease will be followed up until the PICU discharge. We collect the clinical demographic and outcome data, and we also collect the use of PICU resources, include a ventilator using and vasopressor use. And we also collect the microbiology data to identify the etiology of the infection. We do the rapid test as a routine for RSV, the flu A and B, and PCR for adenovirus. We do the blood culture and respiratory specimen culture per clinician opinion. We try to identify the viral and bacterial pathogen from the specimen of 100 patients. We're using the multiplex PCR using the Chiagen kit to test for to detect the pathogen of respiratory specimen. So over 18 months from November 2019, we intended for 1 year initially. However, due to the COVID, so the admission is a disruption. It's not only in my ICU, but also in other countries. So we have to lengthen the duration of the data collection. So over 18 months, we have more than 2,000 admissions, and with more than 1,500 patients with less than 2 years. And accounting for 14.16% of the infant with born prematurely among those less than 2 years of age. And for the children with the respiratory unit, it accounted for 17.1% is premature. So this is quite a large proportion of the children born prematurely. And there's some data in demographic of the 202 children with the ex-premature. The gestational age median about 29.5 weeks, and birth weight is 1.2 kilogram, and admission is at 2.7 months at the median, and weight is 2.7 kilo. And look at the graph here. We divided in the extremely preterm per WHO classification of gestational weight less than gestational age less than 28 weeks, accounted for 1/4, 25%. Very preterm is from 28 to 32 weeks of gestational age, accounted for majority is 42.1%. And late preterm with the GA is more than 32 weeks, accounted for 32.1%. And and there's no difference between the, we compare between the premature and non-premature, and there's no difference in terms of the gender distribution. For the is similar in the comorbidity. We see that preterm infant has more copies compared to the full-term infant. And looking at the rehospitalization rate for full-term infant, yes, about 68% is a premature infant requires the rehospitalization, while the full-term is at only 31% require rehospitalization. So we're looking further for the premature group, and we look here, we see that the 48% in the very preterm, that GA about 28 to 32 weeks requires more rehospitalization compared to the extremely preterm and late preterm. It could be the extremely preterm is lower, might be related to the care and treatment initially. For the diagnosis, in majority of the preterm and in full term, lower respiratory tract infection is accounted for 52% in ex-premature, and in full term it accounted for 88%. So why in preterm infant we see sepsis accounted for about 39%? Why is quite lower in the full-term infant? When we detect in the ex-preterm infant, by the viral pathogen, we see that 53.5% detected a viral pathogen, while in full-term just only 32.8% can detect, and the majority of the viral here is RSV and also other virus. It's quite similar in both term and full-term infant, full-term and preterm infant. Looking at the bacterial pathogen, we see also in the premature infant, we detect that more percentage of the bacterial pathogen, and majority here we see that gram-negative bacteria such as Acinetobacter baumannii and Klebsiella pneumonia, and could be related to the rehospitalization and prolonged stay in NICU previously compared to term infant. While we looking at the resource use in PICU among the preterm infant, we see that they use a lot of the resource in PICU. More than 90% with this requires the pathogen detection by blood culture and respiratory culture, or tested for the virus by rapid test or PCR. With 86% require invasive mechanical ventilation, and more than 50% require echocardiography. This is when we compare between the full-term and preterm infant regarding to using the vasopressor. We also see that more infants in the premature requires a vasopressor compared to non-premature. It might be related to the patient in premature group has sepsis. Looking at the mechanical ventilation as well, the premature infant has more percentage requires invasive mechanical ventilation compared to full-term infant. And the duration of mechanical ventilation, we see that the infant with preterm requires a longer duration of mechanical ventilation compared to full-term. However, there's no statistically significant difference. For the treatment duration in PICU, in the preterm also stay on median of 11 days compared to 6 days of the non-preterm infant, and it's significantly different. And also the hospital length of stay, the preterm infant also stay longer compared to term infant. And we also looking the difference between the gestation age of very preterm, extremely preterm, and moderate to late preterm, and there knows the difference regarding to duration of mechanical ventilation. length of PICU, and length of hospital stay among 3 groups. For mortality, we have a 31.3% mortality in premature group compared to 22.6% in non-premature group. It is significantly different. When we're looking at the mortality by GA, and it's obviously the children in extremely preterm has the highest mortality, 46.2%, and the lowest is a late preterm, is 22%. So in conclusion, this is the pilot study and the preliminary data to see that an preterm infant is significantly the patient population in the PICU, and LRTI remains the major diagnosis of the critical respiratory units, and virus remain the main pathogens. Compared to term infants, preterm infant requires more PICU support and had worse clinical outcome. And future study is a means of intervention that potentially reduce the PICU admission of this infant. So thank you very much for attention.
Thank you for that very nice presentation. Clearly shows that, you know, the burden of ex-prematurity, it is seen even in the pediatric intensive care unit. So we'll keep questions to after the second presentation. So if any of the participants or have questions, do type it in the chat. If not, just raise your hands after the second presentation. And I'm looking forward to that discussion that we'll be having later. So it gives me a great pleasure to introduce actually 2 speakers for the next talk. I'm very happy to introduce Dr. Pustika Efar, who is a pediatrician in the Pediatric Intensive Care Unit at Harapan Women's and Children's Hospital in Jakarta. She's an active member in a lot of medical societies there, and her research interest is in nutrition in critical care as well as severe pneumonia. And the second speaker for our second talk on Indonesia is Dr. Felix Liauw. He's also Pustika's colleague in the Pediatric Intensive Care Unit in the same hospital. Again, very active in many medical societies back in Indonesia, and has published numerous articles in the domain of infectious disease. So I'm very happy to have Pustika and Felix here to give us the next talk. Indeed, they are the young and energetic pediatric ICU people in the region. So very happy that they are able to share some of their experience with us in Indonesia. So over to you, Pustika. Thanks.
Thank you, Dr. Jan Hau. Good afternoon, dear colleague. First of all, I would like to thank you for SingHealth Duke-NUS and Global Health Institute Singapore for having us in this great opportunity. It is an honor for us, me and Felix, and it will be great opportunity to share with you all. Today, we will present the progress on our study on the burden of viral pneumonia in severe pediatric respiratory failure. Pneumonia is the leading cause of death by infectious disease in children under 5. And of all under 5 deaths, pneumonia was accounted for almost 15% of the cases. The etiology might be viral, bacterial, or fungal. But sadly, in the developing countries like Indonesia, the etiology of viral and also the other than bacterial is still underdiagnosed. There are lack of epidemiological data of the burden of the viral pneumonia specifically. The cause of this underdiagnosis of viral pneumonia is usually because we have lack of financial resources, and also the incapability of the lab work to diagnose viral pneumonia effectively. So the viral pneumonia itself often considered as low importance and also trivial. So the antiviral drug not available in our hospital for urgent use. Also, recommendation for viral respiratory vaccines such as influenza is not well developed here.
Pustika, sorry to interrupt. Do you want to share your screen? I think it's not being shared.
Oh, sorry.
Yep.
Really?
Yeah.
Ah. Can you see
Yes.
my screen?
Yep.
Ah,
Thanks.
yes.
Yep.
Okay. Sorry. Yeah. Okay, maybe we'll go to the next slide. Harapan Kita Women and Children Hospital, where I and Felix work, is a tertiary government hospital in Jakarta. We have 18 beds of pediatric ICU. Some of them are covered for COVID also. And pneumonia contributed to 41% of PICU admissions. The main objectives of our study, the first is to determine the prevalence of viral pneumonia in children with respiratory failure. And the next is to identify the outcomes and the possible prognostic factors of viral pneumonia. But because our study is still ongoing, we targeted for 100 subjects. But up to now, from from October last year, we have completed for almost half of the targeted subjects. So maybe we cannot conclude some of our objectives yet. We got the funding from SingHealth Duke-NUS Global Health Institute last year with the PI, Dr. Lee Jan Hau, and site PI, me and Felix. It is a single center prospective observational study with the target population is all pediatric patients with pneumonia-associated respiratory failure admitted to our PICU. We will collect the data, demographic, clinical, laboratory, and the outcome, and specifically about the microbiological investigation. We did the standard investigation with bacterial culture from tracheal aspirates, and we add a specific test, rapid multiplex PCR using BioFire to diagnose viral pneumonia, but also they can detect bacterial and also atypical microorganism as well. The first patient enrolled was on October last year, and the latest patient just now is last week, November 12th. We got a total of 53 patients up to now. Male and female are comparable, and most of the subjects are less than 1 year old, and majority have respirator support with invasive ventilation. The survival rate for our pediatric pneumonia with severe pneumonia and respiratory failure is about 60% survive here. The underlying diagnosis we collected are congenital heart disease, cerebral palsy, or other CNS abnormality, and also Down syndrome with underlying disease, congenital heart disease. Some of them are positive in SARS-CoV-2, and sadly, while we have a surge in SARS-CoV-2 patient in last July and August, we run out of the test for the BioFire panel, so we cannot enroll the patient at the time. The main problem we faced in our study is the delay of the test itself. The lab worker usually only available on the daytime. On the morning shift, they go home after 3 o'clock in the afternoon, and afterward we cannot do the test immediately. We have to delay the test until the next day, or if the weekend arrives, so we will have a delay for about 2 or 3 more days until the Monday comes. This is the main finding of our study. We find viral causative agent in 41% of the patient, and bacteria in almost 80% of the subjects, while in 5 patients, almost 10%, we have find no microorganism at all. The viral only, we call it sole viral etiology, find in only 6 patients, 11% of the subjects. And the only bacterial cause is detected in 49% of the subjects, and the combination of viral and bacteria find in 30% of patients. The most common bacteria detected are Klebsiella pneumonia, Pseudomonas aeruginosa, and Staphylococcus aureus, and the rest are various, as you can see in the screen. We also find that the antimicrobial resistance is quite high. Only 26% of the specimens have no resistant gene. We see that the most common resistant gene is CTXM. So we can conclude that the patient with CTXM gene usually resistant to cefotaxime, ceftriaxone, and other cephalosporin antimicrobial. So we see that the patient usually resistant to our first-line antibiotics and need more escalation to second-line or third-line antimicrobial agent. So from our study, up to now, from 53 patients collected today, we can see that the majority of the patient usually have sole bacterial etiology. The viral etiology as the sole causative agent found in only 11%, with survival for about 50%. In patient who has bacterial as the sole agent, have survival rate higher, 73%. And while those with combined viral and bacterial etiology survive in almost 70% cases. So maybe this is a bit not usual finding, where we find the patient with sole viral etiology have the worst survival here. So maybe this is the first part of our presentation. The next, Felix will continue with our analysis. Felix, please.
Yeah, thank you, Dr. Pustika. Yeah, thank you, Dr. Pustika. So we are going to have a brief discussion. So as you might note that pneumonia is still a leading cause in children, according to WHO, especially in children under 5 years old. And as the causes, bacteria, virus, and fungal, if we already identified the causes, so we can give the best appropriate treatment. However, sputum culture and also sputum gram stain and also PCR from the sputum are not routinely performed in Indonesia, especially because of the facilities and also the cost is too expensive. So in Indonesia, mostly pediatric pneumonia treated with antibiotics, and antiviral is not available actually at this time. And we see that the other sites, other reference in Singapore, for example, Phuc Huu in Singapore also did almost the same study. They found that the sole viral as the common etiology was 17.9%, and the common etiology was RSV. And it is stated that the viral pneumonia has a greater risk to cause acute respiratory distress syndrome than other etiology. Other sites in Beijing, in Phuc Huu in Beijing, also performed nasopharyngeal aspirates. It was found 77% virus was detected, and similar with the Singapore, the commonest etiology was RSV. And the other sites also in South China. In South China, next slide, please. Okay. In China, it was found that 54.9% virus detected. The sample also collected with from the nasopharyngeal spirits, and again RSV the common, and also in Sarawak, Malaysia, using the nasopharyngeal spirit with PCR, 48% virus detected, and again RSV was the main common etiology. It was different with the small study which was performed in Surabaya in East Java. From 45 patients in Surabaya, it was found 77.8% virus identified as a cause of pneumonia in pediatric there, in children there. And the etiology, the commonest etiology was enterorhinovirus. This finding in Surabaya in East Java was quite similar with our findings. Our temporary findings also found 21% the virus was human rhinovirus or enterovirus. And so actually this is our pitfalls for these findings. Whether which one is better if we collect the samples from the nasopharyngeal or from tracheal expirate, which one is better? Because some studies found that viral detected in upper respiratory tract are less pathogenic. And the pitfalls, and the second pitfalls, you also think that the PCR, the multiplex PCR, cannot differentiate between whether the bacteria or virus is a colonization or really a true pathogen. And you also found that the PCR might be too sensitive, so it can detect the colonizations or infecting pathogens, and it might cause the overuse treatment might be. And the fourth pitfalls that we might also consider that we think that there is no CT value of the virus with the PCR, and some research suggests that the CT value of the virus, which will be considered as a true infecting pathogens, is with the CT value under 24. So as a summary, that in our temporary findings, the burden of viral etiology in acute respiratory failure in our study, I think it is need to be considered. And if it is need to be considered, I think we should make like an agreement with which one which one is better to collect the samples, which is from nasopharyngeal or from the lower tract or trachea or bronchoalveolar average. And we also would like to know other countries' experience if they found viral etiology as the pathogen in the pneumonia. Do you all have an access to antiviral, or give also and treat the patients with antiviral, or maybe just give supportive agent like corticosteroid or just observation? Thank you, Dr. Pustika. Thank you, Dr. Jan Hau. Over to you. Thank you.
Thank you, Felix and Pustika, for that very nice presentation and sharing of your experience in terms of clinical practice, as well as some of the research logistic challenges that you faced for this pilot study. So thank you all for the presentation to Phuc, Pustika, and Felix for the nice two presentations. We shall move on to the section on discussion so that we can have some useful exchange of ideas between some of our colleagues in Southeast Asia in particular. I don't see any questions in the chat, so if any of the participants, if you have questions, do raise your hand and we'll unmute you so that you can ask your question and have some discussion. Perhaps I can just kickstart this section, and obviously from the two presentations, without a doubt, pneumonia has a high burden in Southeast Asia, and more so in children less than 2 years old. And this is consistent with the WHO data that pneumonia is a major killer in children under 5. And I think from these two presentations, as well as our experience in Singapore, even though Singapore is a developed country. Pneumonia still is a major concern, and I think research and improvement in care in this area is critical or highly important. So perhaps I can start the discussion going by asking Phuc. You mentioned that the burden of these ex-premature infants, obviously from the talk, is fairly high. And your ICU, I noticed that you are able to take care of children beyond 1.6 kilograms based on your demographic data. So can I ask, what's your lower limit in terms of either gestational age or weight that your ICU can manage? And has it always been the same, or you have put in steps to be able to cater for younger and younger or lighter and lighter infants over the years?
Thank you, Jan Hau. Your question is also kind of like controversial in my hospital in terms of, because the policy for admission to PICU and NICU, usually in NICU, in PICU, we receive the patient from 30 days of age up to 18 years old. And for the premature infants, they might stay in NICU for maybe up to 2-3 months, and few kids, they stay there until 6 months. So in my ICU, we base on the age of the infant admitted, not because of the weight. However, in my hospital over the last few months also, as I said before, we discussed about the policy admitting the small baby to NICU or to surgical ICU, medical ICU. So we decided that for the baby less than 1.5 kilos now, disregard to the age, we admitted to the NICU. If the patient has some problem relating to cardiac problem, they will be admitted to CICU. And but because of our NICU, they always overload of the patient, so the best availability not always available. So we sometimes we have to admit the patient less than 0.15 kilo. And I don't know about, not sure about in Singapore, in Indonesia, in other countries in the region, when you admitted the premature infant to PICU, it depending on weight or the age of the infant, or is both factor.
Yeah, I think Phuc, you brought up a good point. Really, logistically, it also depends on nursing care, and of course the equipment that are available to cater for these very young patients. And there are other settings that have a combined PICU and NICU, meaning the neonatal and PICU are actually run by the same team of doctors in certain places around the world. But at least in Singapore, it is separate, and usually our lower limit is 1.8 kilograms, and regardless if they are borderline premature, and if our neonatal ICU is full, sometimes we do take the patients to our PICU. And of course, our nurses will need to be comfortable managing these very young infants, and also the type of diseases in the early neonatal period is somewhat different from those that are being admitted back to the ICU a bit later. And from your presentation, rehospitalization is indeed a problem. How about Pustika and Felix? What is the youngest age or gestational age or the weight that you have managed in your pediatric ICU, and does it cause any challenges for your team in Indonesia?
So I think when the NICU want to transfer to PICU, it only based on the correction age, not from the birth weight, so not from the body weight. So as long as the corrected age are already up to more than 1 month, so they will transfer to PICU, no matter how much the weight, body weight.
Okay, yeah, good to know. Obviously, this highlights the difference in practices, and I think moving forward, as our neonatal colleagues, there's marked improvement in the quality of care provided in our NICU. There will be more and more survivors from the neonatal period that we'll be seeing, and same goes for pediatric intensive care and pediatrics. As our standard of care, quality of care improve, then more of our children will survive to adulthood. And I think even now the adult physician will need to be more and more comfortable managing childhood diseases that are now going on to adulthood, and some even have children of their own and have ONG issues and stuff like that. Perhaps one more question for Phuc before we change to our attention to Indonesia. So based on the study of findings, Phuc, any area that you can bring up to your hospital management or even in Vietnam to advocate for critical care provision or medical support for these ex-premature infants? Because obviously I've highlighted they have a high burden, right? Even those who are admitted with respiratory illness, they require more inotropes, more ventilation. So any important pilot data that we can bring to your hospital or in Vietnam to help improve the care of these children?
Actually, for premature infant in Vietnam over the last 10 years, with the advance in NICU, so the more and more baby born premature can survive beyond the neonatal period. And also the data from our pilot study to see that quite a large proportion of rehospitalization and admitted to the PICU, and they has a worse outcome and also requires a lot of the resource in PICU. So the data, this data we also report to the hospital in terms of like the best occupancy for the PICU when once the premature baby they stay longer in ICU compared to the full-term baby, and also requires more resource and higher mortality. So I think this is a pilot study, and then the very initial data can bring up to not only in my hospital but also other children hospital in Vietnam, because we have 3 referral children hospital in Vietnam facing the same condition of the PICU with sometimes, as I mentioned in my presentation during the last year because of COVID-19, and so the number of the patient admitted decreased. But sometime in 2018 or 19, sometimes they might accounted for 1/3 of the patient in PICU with prematurity. So this is a quite high burden, and we also face the condition that NICU of the referral children hospital always overcrowded. So the premature infants, they might stay in the local hospital until beyond the 30 days, and then they refer to it, and then they have to admit it to PICU. So that's the reason we're looking at the data for the more detail are not presented in my presentation. Maybe 90% of the patient admitted to my ICU, they did stay in the NICU of the previous hospital. They should be admitted to NICU in my hospital, but because it's overcrowded, so they have to transfer to it. So I think this data can very good indicator for the policy of the hospital in terms of for more appropriate preparation for PICU, and also some intervention to decrease the risk, the severity, not only in my hospital, but from previous hospital. And as I mentioned before, we changed the policy in terms of body weight for the premature, less than 1.5 kilos should be admitted to the NICU because of the facility and experience from our college in NICU is much better than to take care of the small baby. I think this is also one of the policy we changed based on the data we reported.
Thanks, Phuc. Do we have any question in the chat, Amina?
Yeah, so there's a question on the chat. It says, I'd like to know whether home ventilation is offered to these ex-premature infants with chronic lung disease, and whether or not home ventilation has resulted in reduced readmissions or healthcare resource utilization. So I guess for either country.
In Vietnam, we do not have home ventilation program for premature infant. We do the home oxygen therapy for premature infant who has like BPD or pulmonary hypertension, requires a long home oxygen therapy, but ventilation is not available. But I think it's also quite difficult in the limited resource settings like in Vietnam or other country. I don't know about in Indonesia and Singapore and other countries in the region for this population.
Pustika or Felix, you want to share your experience?
Yes, our experience with the home ventilator was start in 2018 actually. So we have 5 patients at that time with the home ventilator. 1 patient with spinal muscular atrophy type 1. Unfortunately, he was died. But
You went on.
Still survive. The underlying disease from those 4 patients, one is a Pompe disease. It was a metabolic disease, and 3 of them with the chronic lung disease and palsy cerebrals. They got the home ventilator from the crowdfunding. So our hospital make crowdfunding, and then after we collected about 150 million rupiah, maybe it's about 15,000 Singapore dollars for one home ventilator, and I think we in our experience that the home ventilator can give a better prognosis for the child. Thank you.
So actually, I kind of had a general question, which maybe even Jan, how you can comment on it in terms of Singapore. So every country has its own very specific set of circumstances, which has been outlined very nicely in the presentations. But I was thinking from a kind of regional perspective, are there things that we can learn from each other? Where are the points of similarities, or where is it so divergent? The environment and the context is so divergent that really you have to like carve your own way. So, it's a pretty kind of broad level question, but are there some things that have kind of emerged that stick out in this way?
Yeah, Amina, I think that's a good question. And, just using the example of home ventilation where we send patient home on some medical devices, right? In Singapore, we have a good home ventilation program supported by our complex care team in KK Women's and Children's Hospital, as well as NUH has their own team. But Singapore is small, right? And to offer parental support and logistic support is much easier compared to Vietnam, and even more challenging in Indonesia, where they have more than 200 islands, right? So how do you send a patient home on a ventilator, and that patient may be coming from a faraway island? So while we know that a home ventilation program or a home care program will work, but it really depends on where the patient came from originally, and do they even plan to go back to their own region? And I think as we plan ahead within the region, we need to consider these unique challenges. Even like Vietnam is a long, geographical country, right? And it would transport be a problem. but Singapore, we are quite fortunate. It's very small, and help and access, will not be such a logistic issue, and that's probably, while we know that getting the patient home as early as possible is always advantageous, but I think we need to adapt some of these to the local and regional challenges that each country may have. Yeah, and I'd like to hear Phuc or Felix, are there talks about getting some home care, or for some of these more complex patients in your country?
We also have home ventilation and home care for some cases. For the adult patients, they do have, especially for COPD and other chronic conditions. But for children, we have some patients with the home ventilation and home care. We do not have KAIAPLA's formal program, but some patients with the neuromuscular disease like SMA or the neural consequence of the hand, foot, and mouth disease, they might require very long ventilator dependent, and then we do. But for premature infant, mostly they premature and KAIAPLA quite difficult to take care at home if they are on ventilator. So home oxygen therapy, I think, is just the only you can offer for this patient. But I don't know regarding to geographic location and also a problem because we have only 4 tertiary children hospital, 1 in the north and 3 in the south. And if they live far from the referral hospital, I think also a problem in terms of you want to setting up a home care or home ventilation program for these patients. And mostly the patient as I mentioned, who has a neuro condition or SMA or something like that, mostly they live in the large city when they are quite close to the referral hospital.
Yeah, thanks, Phuc. How about Pustika and Felix? Any home care arrangement, at least within Jakarta,
Yeah. I think Pustika will answer.
Honestly, Dr. Jan Hau, we don't have an official home care in our hospital. And about the patient readiness and also the parents' readiness to have their child at home with home ventilator is quite challenging. We have some other candidates for home ventilator, those with chronic lung disease, refractory epilepsy, and CP, but some of the parents are just not ready. They might show some reluctant to bring their home ventilator, so they just bring their child home and then have another readmission to hospital. So when we trace our patient back with home ventilator, we think the main factor for the success of the home ventilator program is the parent readiness, how they can provide the care for their children, how can they provide sufficient oxygen in their home, how to troubleshoot the ventilator, and how they can easily contact us, doctor or the nurse in our hospital, and ask for a suggestion. So we don't have any official home care, but unofficially they contact us by WhatsApp or messaging to ask some suggestion, and then some of us will come to their house for some visit. Yeah, not official from hospital, but yes, we try to help as much as we can.
Okay, thanks, Pustika.
So, you know,
no. Yes, Amina, go ahead.
so, sorry, I know we're running out of time, but all this conversation actually leads me to thinking of another kind of related topic, because, you know, we've been increasingly, SDGHI, along with partners like CORE and IPSQ, have been increasingly engaged, being engaged in the space of patient engagement and patient empowerment. So your comments were really making me think about our conversations that we have there. Of course, in this case, it's the caregivers, because obviously the patients in your case are, you know, too small, but, you know, the parents are very involved. And I don't think we have time to go into it, but it will be an interesting kind of way to link these two topics of how to really think about engaging the parents to be able to, you know, Pustika, you mentioned some of the issues of taking it home and how you're caring, but maybe they're educational ways, maybe they are, you know. So I was wondering if you've had any experience or, you know, have any thoughts about how to kind of engage more along that spectrum. Anyone, if you've had any thoughts. I mean, it was just something I'm throwing out there because we've been working so much more in this space, and it really seems we need to be working hand in hand with all the healthcare workers, as well as, you know, everyone else who's a stakeholder. Obviously, the patients and their parents are very much stakeholders.
I don't know if I don't know if my answer will able to fulfill your question, Amina, but in our hospital, usually the patient who will be sent home with home ventilator, we ask the parents to stay in our PQ 24 hours to see us how to suction and how to change the tracheal tube and how to all care for their children. They have to watch us, nurse and doctors, how do we do it, and we will teach them how to do it. And then before we can send them home, the parents should be able to practice all the care to their children in good way. We also give them some a home care book, a home ventilator book, a guidebook. Consists of what equipment they need to provide in their home, what should they do when the child shows some emergency condition, and where should they bring the children in the future when they need us. I don't know. Is my question? Is my answer?
Yeah. It's all, you know, kind of. Yeah, it's just like important, interesting to think about what you can do. And yes, certainly those are steps along the way.
Yeah, it's limited. Yeah, we try our best.
Yeah, thanks, Pustika. We are running slightly over time now, but we have just one last question for our colleagues in Indonesia. Obviously, from your presentation, it seems like bacterial pneumonia is more of a concern in at least your hospital in Jakarta compared to some of the data you presented, where RSV and even Phuc's presentation, it seems like viral pneumonia is of importance. So I suppose the challenge for our team in Indonesia is how then can we advocate for, you know, you mentioned that some of the antibiotics used for this bacterial pneumonia is not ideal, right? And that your challenges is the laboratory turnaround time that is a bit slow. So do you have any preliminary ideas on how you can use this data to push for some changes within the hospital, knowing that bacterial pneumonia and the antibiotics that we use can be optimized?
Sorry, Jan Hau, thank you. I think from these temporary findings, we will make an idea to push the infectious disease consultant to ready to escalate the antibiotics once we got the results. However, managing the laboratory staff will be much difficult from us, because it should be managed by our director to control, to make a good laboratory staff shift. But I think from our Phuc Huu doctors, I think we can push the infectious consultant to give to escalate the antibiotics as soon as possible. I think Pustika want to add something. Okay.
Yes, like I have mentioned in our presentation earlier, we find that the majority of the patient shows antimicrobial resistant, minimum one gene, resistant gene. So maybe in the future, we should change our policy for first-line antibiotics, maybe if it's possible. And then if we, if our study finished and we think that the pneumonia panel film array is cost effective, so maybe we should make some suggestion or recommendation for the use of the panel. But if not, maybe we just change the first line antibiotics. And maybe I will add some question to the Jan Hau or maybe other colleague in another country. How do you use antiviral agent in childhood pneumonia? If you find some viral etiology such as RSV or parainfluenza or influenza virus, do you directly give antiviral, specific antiviral to the patient? I don't know. It might be useful for us to give some recommendation for the next future for our patient. Thank you.
Yeah, thanks, Pustika. I think I'll take that. I think antiviral use, at least in my hospital, is dependent on the patient comorbidities or past medical history, as well as when they present to us. If they present to us fairly early and they are really sick with let's say like ex-prematurity with congenital heart disease and very high risk of further deterioration, then we will use some specific antiviral depending on the virus that we've isolated. Of course, if they present a bit later or there are actually no comorbidities, we don't routinely use antiviral or specific antivirals for this purpose. And we do know that the evidence, for this is still, not strong, perhaps only in a certain subset of patients, right? So I think, given Phuc's data and, your experience, we probably need to go on a case-by-case basis and whether, it is cost-effective to use antivirals depending on the time of presentation, comorbidities, as well as, how sick the child is. Yeah. So, I think we're running short of time. There will be actually a few more discussion points, but I think we should, draw this session to a close. I'd like to thank, Amina for helping to organize this, and for Phuc, Felix, and Pustika for taking their time off in sharing their experience, as well as the the admin staff at the Global Health Institute for helping to organize this, and also for everyone who has taken the afternoon to hear some of this experience. So, I mean, any other comments before I close this?
No, I just wanted to also, echo back the thanks to all the speakers and to you, Jan Hau. It was great to have you guys on this our seminar series. It's very interesting, and we kind of get the opportunity to know that we at least had some small part in, supporting this project. So it's great to see how they come along, and you share this discussion. As you're saying, we could continue the discussion, but we'll have other opportunities. And to the audience, thank you again for accommodating the change of timing, date that we normally have it, and it's great to see all of you. I just do want to point out, in December we don't hold our seminar series because last Friday we assume everyone's gone and most of us are also on leave. So we won't have our seminar series next month, but look out for it again in January. So we'll be, we already have an interesting lineup of speakers. So we, look forward to continuing that next year. And thank you all for being here. Thank you for being the last panel discussion for the year. So be safe. Great to have you. Thank you, everyone. Bye-bye.
All right. Thank you, everyone. Stay safe. Okay. Okay,
Thank you, Jan Hao.
thanks,
Thank you,
Felix.
Thank you,
Amina.
Jan Hau. Thank you,
Thank
Dr.
Felix.
Amina.
Lee.